You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 2nd, 2023. This week, listener feedback on the most important study of perhaps a decade, the Monitor HF study, a flawed paper and analysis, and the tension between pathos and logos. First, I want to do some listener feedback. Within minutes of the podcast dropping last Friday, an astute listener informed me that I misspoke about the Paradise MI trial of sacubitril/valsartan. I said it was versus valsartan alone, but that is wrong. It was against ramipril. I knew that, but I got excited. So thanks for the correction. Of course, the context here is that other than Paradigm HF, sacubitril/valsartan has not impressed in other outcome trials. We should definitely repeat Paradigm HF, and FDA should have stuck to their norm of having 2 regulatory RCTs. Now, the big story last week was publication of the ELAN trial. I called it the ELAN trial, which is yet another mispronunciation from an American. I'm sorry to the ELAN authors. ELAN was a super special RCT, not because of the treatments that were tested or their effect size, but the way in which the trial was conducted and presented. Now, the question in ELAN of early versus later initiation of oral anticoagulants after an AFib-related stroke is an important question. The trial found that early versus late initiation reduced the composite primary outcome of recurrent ischemic stroke, embolism, major bleeding, symptomatic intracranial hemorrhage, or vascular deaths within 30 days. The hazard ratio of the reduction of that composite primary was 0.70, so that's a 30% reduction. But now you might ask, hey, Mandrola, you forgot to tell us if this was a positive trial. What was the confidence intervals? What's the p-value? Was this significant? And that's the provocative thing. The ELAN authors made no such proclamation. The confidence interval ranged from 0.44 to 1.14. They did no statistical test. There is no p-value. And the conclusions in the New England Journal of Medicine read that the incidence of the primary outcome with early versus late initiation of anticoagulation was estimated to be from 56% lower to 14% higher. Period. This is darn amazing. They encourage doctors to be mature, to not rely on the dumb dichotomy of positive or negative results. Instead, they wrote in this trial was designed to estimate the treatment effect of early versus later initiation of anticoagulation, as well as to estimate the precision of the estimate. Their protocol paper said 2 sentences that just stick out in my mind. Quote, although we propose a different analytic approach to that often seen in clinical trials, this should not hinder interpretation of the data or its clinical utility. We also believe that the complexity of managing patients with AF early on after ischemic stroke precludes simplified, dichotomous decision-making, and it necessitates some leeway for individual decision-making. This makes me tingle with delight. It totally supports my view that guideline writers should resist the urge to put therapies in those colored boxes of recommendations. Rather, guideline writers should review the literature and doctors would be responsible for melding the best evidence with clinical judgment and patient preferences on an individual basis, just like Sackett said we should do. Now, that view brought strong disagreement with a European academic whom I have amazingly high respect for. She wrote to me And I think her words are important to read. She says that I disagree with you when you say that colored boxes are not useful in guidelines because they oversimplify decisions. She believes that we have to remember what was the driver of starting these recommendations in the first place, and it was a way to standardize treatment and protect patients from physicians who don't keep up with updates and may make decisions without having all the information and evidence into account. Moreover, she goes on, these boxes help clinicians' discussions with payers about reimbursement. Not everyone is able or takes the time for critical appraisal of published data, and the potential arbitrariness of this new approach may hinder evidence-based decisions. And she concludes by saying that if we want to disseminate knowledge and widely implement simple treatment strategies, we have to keep it simple. Okay, fair. My response to this definitely majority view, this is the majority view, is first to thank the listener for listening and taking the time to write to me so thoughtfully. And yes, I agree that there is a lot of bad care out there. I wish there wasn't. But I would rebut the argument that colored boxes protect patients from poorly informed doctors by saying that for each case that the simplified recommendations helps the doctor make a good decision, it also gives a profit-driven doctor license to overtreat. Here in the U.S., from the position of my lens, if a therapy is even in those boxes, say a 2B level of evidence C, the lowest level, this can still be used by American doctors to overuse things like ICDs, AF ablation, appendage closures, stents, both peripheral and coronary, etc. It doesn't matter if an expensive, low-value therapy gets a 2B level of evidence C. If it's in the guidelines, if it's in those boxes, it's fair game to be abused in a profit-driven system. As for the matter of using guidelines for making payers' decisions, this is extremely complex, not least because of the competing interest. Now, to be fair, I don't have an easy rebuttal for the decision to use guidelines for payers' coverage, but why not apply similar logic, right? For every inappropriate procedure prevented with these simplified recommendations, they can also be used to overtreat. I mean, European guidelines haven't seemed to resolve the differences in procedure use from, say, Germany versus Portugal. Now, one more interesting feedback from last week's podcast. Professor David Cohen, who you should be following on Twitter, wrote to me to say that the New England Journal of Medicine has actually published a previous trial that also had a moderate sample size and an exploratory statistical approach. This was the STREAM study of pre-hospital fibrinolytics in patients in whom PCI would be estimated to take longer than an hour. Paul Armstrong is first author. This was 2013, and I'll link to the paper. They found that pre-hospitalytic versus going straight to PCI led to a 14% lower relative risk of a MACE endpoint. Now, the confidence intervals range from 0.68, 32% reduction, to 1.09, a 9% increase. The thing is, though, they still calculated a p-value and declared that this was no difference. But the discussion of this paper was even weirder. Here, they sort of explained that factors such as not having enough funding, a global shift to primary PCI, and the difficulty in pre-hospital randomization induced them to do a smaller trial without a primary statistical hypothesis. Then they went on to write that the upper limits of the confidence interval, which was 1.09, essentially excludes anything greater than a 9% increase in MACE. And they write that although this was not a non-inferiority trial, most non-inferiority trials use margins that are greater than a 9% increased risk, implying, I think, that this could be considered non-inferior. Now, I don't know about you all, but this is an intensely interesting concept to me because what Stream and the ELAN authors seem to be saying is that we're going to do this trial. We're pretty sure that we can't enroll enough patients, and we do expect wide confidence intervals, but we're going to leave it up to the user of evidence to apply the results. And I love the idea of letting doctors interpret evidence without made-up thresholds of significance. But I also would not want this exploratory approach to enable underpowered trials, because when you look at the confidence intervals of ELAN and STREAM, it seems to me that it wouldn't take in many more patients randomized to increase the precision of the effect size. Now, I know, listeners, I know I'm spending a lot of time on this idea of trial interpretation, but it is super important for the entire evidence-based approach to patient care. All right, next topic is Monitor HF study. I'm going to need to be careful here. I mean no personal malice towards the authors of the Monitor HF trial, or Professor Angerman, who wrote the editorial, or the editors and peer reviewers of The Lancet, but this is a difficult story to tell. Monitor HF is a Dutch RCT comparing the use of the CardioMEMS PA pulmonary artery monitoring system in patients with heart failure. Lancet published a study of 348 patients. Half were randomized to have their heart failure managed with the wireless clip in the pulmonary artery. Half were treated with standard of care. The primary endpoint was a subjective endpoint measuring quality of life, the Kansas City Cardiomyopathy Questionnaire, or KCCQ. KCCQ is a patient-reported questionnaire. It includes bunches of questions that ask patients to assess things like their physical limitations or symptoms or self-efficacy, quality of life, even social limitations and emotional well-being. The patient responses are on a Likert scale, which gives numbers to their responses so it can be quantified. Monitor HF was not powered to detect clinical outcomes. The authors of Monitor HF tell us in the first sentence of the methods, quote, "This was an open-label RCT." In other words, one group got a fancy, wireless, invasive monitor. The other group got nothing. And, of course, the results are positive with a qualitative endpoint. The mean change in the KCCQ overall summary score at 12 months was 7 points, which was highly significant. Also positive with heart failure hospitalizations. It was a 44% reduction in heart failure hospitalizations. Of course, the absolute risk reduction was minimal, a delta of only 0.3 heart failure hospitalizations per patient years. Now, CV death and all-cause death were similar in both arms, but remember, Monitor HF was not powered for clinical outcomes. The authors concluded in The Lancet, hemodynamic monitoring substantially improved quality of life and reduced heart failure hospitalizations in patients with moderate to severe heart failure treated according to contemporary guidelines. Quote, "These findings contribute to the aggregate evidence for this technology and might have implications for guideline recommendations and implementation of remote pulmonary artery pressure monitoring." Wow. The accompanying editorial had 9 paragraphs. One paragraph in the middle discussed the stomping elephant in the room here, namely that Monitor HF was an open-label trial that measured a totally qualitative endpoint. But she then dismisses the fatal, and I mean fatal flaw, by arguing that pulmonary artery pressures and BNP values were nominally lower in the CardioMEMS arm. She then spends 3 paragraphs lauding these positive findings. A, it's consistent with previous trials. B, it's a positive for CardioMEMS in a different healthcare setting in Netherlands as opposed to U.S. I highlight this quote from the editorial. Quote, "Together, findings provide robust information for healthcare providers, regulatory agencies, and payers about the potential of pulmonary artery pressure-guided heart failure management." End quote. Now let me read you the 9th paragraph of this editorial. Quote, "I declare personal fees from Abbott for serving on the chair of the steering committee for the MEMS HF study, which evaluated the CardioMEMS pulmonary artery pressure monitoring technology manufactured by Abbott. I also disclose consulting fees and speaker honoraria and reimbursement of travel costs from Abbott." End quote. Now, before I tell you my comments, let me also add that the altimetric Chrome extension that I use reveals that 71 news outlets carried this trial with glowingly positive headlines. More than 100 tweeters sent it out, almost none of them with any criticism. So my comments. First, critical appraisal guru Dr. Sanjay Kaul. Thank you. Dr. Kaul had the sober and wise tweet. He contrasted the Monitor HF study with Guide HF, a trial that had 3 times the number of randomized patients, and it had a proper blinded arm, and it found no difference in KCCQ. My friends, this story is as depressing as it gets for me. I believe in medicine. I welcome innovation. I've seen lives saved and extended by advances in medicine. I was in Indiana when Lance Armstrong was treated. The man had brain mets from cancer and was cured because of medical innovation. I have similar stories about friends and family who have been cured. Medicine is replete with stories like this, and we need innovation. But this is terrible. This is a totally broken trial. You cannot assess quality of life when one arm gets an invasive treatment and the other arm gets nothing. It would be like a pain trial wherein one group is told their injection has strong doses of morphine and the other arm is told they get nothing. But that's not even the worst part. There are tons of broken studies. The worst part is that this is spun by the authors and the editorialist as positive. Media covers it as positive. Twitter people covering it as positive. It contributes to the marketing power of an expensive device that shows little to no evidence of efficacy. Recall that the Guide HF trial failed to meet its primary endpoint, but gained approval based on a post hoc pre-COVID sub-analysis that barely met significance. Let me make a broader point about medical conservatism. My friend Andrew Foy and I have talked about this. Medical conservatism is basically about a vision. It's like Thomas Sowell's conflict of visions between constrained and unconstrained visions. The medical conservative vision is one of skepticism, that most stuff doesn't work or works marginally. True breakthroughs like insulin and antibiotics are rare, and we believe that skepticism is most consistent with true scientific thinking. But the alternative vision is one of optimism, and this isn't all bad. Optimism is necessary for innovation. Just like the unconstrained visionaries in Sowell's view, optimists believe that if we just keep trying hard enough, we can find a cure that ails all of humanity's ills. And if this was a fair fight, with no camp having their hand on the scales, the conflicting, skeptical, and optimist visions would likely come to a draw. Empirically, I think that we have the stronger argument. Most people don't want low-value extra care. Most things don't work. Now, a therapy that increases lifespan by 2 to 4 weeks wouldn't move the needle. And that's generous because most therapies in cardiology can't even look at mortality anymore because it would make no difference. A study without a proper placebo arm would be dismissed. The skeptical vision would win. But Monitor HF shows how this isn't even close to a fair fight. The optimists have industry backing. They have all the dollars. The dollars from industry not only support researchers and editorialists and journals, but they also support the professional societies, and they get infused into guidelines, which then get translated to standard of care. I mean, walk through the expo of any cardiology meeting and you can see the influence. One company at the ACC meeting had an NASCAR with drug labeling on it. Moreover, Andrew Foy, Sanket Dhruva, Mohammad Rouzier, John Mandrola will never be elected president of ACC. Industry would say, well, what are you all thinking? CardioMEMS is a perfect example. A skeptic has no chance. Not only does the device make money for the company, but each time it transmits data, it creates a bill. It's a cash machine for all its stakeholders. And profit is fine. I'm not against profit if it improves quality of life or extends life, but obviously anyone who looks at this data without the spin would know it doesn't do those things. Now consider that the company that makes the device contributes to professional societies. It will be written into guidelines, just as I quoted you in the editorial. It's not a fair fight. And here I picked on CardioMEMS, but there are many other examples: sacubitril valsartan, left atrial appendage occlusion, early AF ablation, vascular screening, and the list goes on. My friends, if you have time, take a look at The Conflict of Visions by Thomas Sowell. It's such an amazing book. Tell me I am wrong. Send me a note. Convince me not to be cynical, because I am sad today. Third topic today is the story of intensive treatment of hypertension in hospitalized older patients. This is a bit of a conflict between pathos and logos. The longer you practice medicine in a hospital, the more cases of harm you will see from overzealous treatment of a high blood pressure reading in an older person. The standard scenario is this: an older person is in the hospital, often for a non-cardiac condition. He or she is anxious, maybe in pain. Maybe they have missed their morning blood pressure meds. A nurse records a blood pressure of 210/90, and blood pressure is a vital sign. The nurse is concerned and calls the doctor, who then orders a potent blood pressure-lowering drug, sometimes by vein. 2 hours later, the patient falls in the bathroom and breaks a hip, suffers pneumonia after the hip surgery, and subsequently dies. Now, I know this is pathos, not logos, but despite these stories, not much has changed. I, and likely you, still get calls tempting us to treat this abnormal vital sign, high blood pressure. Well, Tim Anderson and colleagues at Beth Israel and UCSF have attempted to turn all this pathos into logos, into logic. JAMA Internal Medicine has published their large retrospective observational cohort study of 66,000 veterans who were older than 65 years. Their goal was to study the association of intensive treatment of a high blood pressure reading with clinical outcomes in hospital. All these patients were admitted for non-cardiac reasons. The authors defined a blood pressure intervention as receiving one or more intravenous antihypertensive doses of any class of medicines or oral doses of blood pressure meds not being filled prior to the hospitalization. All these patients had elevated blood pressure readings in the first 2 days of the admission. Now, the authors now had two groups, right? Non-random comparisons, of course. One got intensive treatment for blood pressure and one did not. They attempted to do a trial emulation, which we talked about a couple of weeks ago. And they had some pretty good assumptions. One assumption was that there is great heterogeneity in who gets treatment for high blood pressure readings. It's sort of random, right? They then defined an exposure window of the first 48 hours. Read times 0. Now, the study outcome was a composite of many bad things like death, AKI, stroke, myocardial injury, BNP elevations, and ICU transfers. Now, since these were non-random groups, the authors used propensity matching, and they used something called an overlap weighting approach, and it's way over my pay grade, but it appears to be robust. The results are unlikely to surprise anyone who works in a hospital. First, patients who received early intensive blood pressure medicines continued to receive those medicines during the remainder of the hospital stay. It was like 6 versus 1.6 medicines, respectively. And the big results, intensive blood pressure treatment was associated with a statistically significant 28% higher odds of experiencing a primary outcome event, odds ratio 1.28, with very tight confidence intervals of 1.18 to 1.39. IV blood pressure medicine had the highest association with the primary outcome, and this was at 90% or 1.90. And these associations were consistent across subgroups, and the authors concluded, quote, "These findings do not support the treatment of elevated inpatient blood pressures without evidence of end organ damage, and they highlight the need for randomized clinical trials of inpatient blood pressure treatment targets." Now, note the causal language in those verbs. In my comments, this paper got a nice discussion on Twitter. The lead author, Dr. Anderson, had a nice thread. It induced many good comments. By the way, this is a great advantage of Twitter, as it can be the discussion section of a study that used to occur in one room at a meeting, but now the discussion can occur globally, and it's awesome. Now, the momentum of the commentariat on Twitter was that we do great harm when we treat isolated high blood pressure readings in older patients who are admitted for non-cardiac reasons. We should stop doing it. Less is definitely more in this case, and I get that. I have seen the harms. I have seen the pathos. And in the early years of this podcast, I would have leaped to the conclusions of most commenters that this study confirms our prior beliefs based on experience that intensive blood pressure treatment in the hospitalized elderly is a bad thing to do. It's right out of Bayes' theorem, right? You have prior beliefs plus the strong associations in this study equals an even stronger belief after the study. But now, after spending many podcasts on the dangers of making causal conclusions from non-randomized data and just weeks ago covering a highly imperfect attempt by super experts to emulate RCTs with observational data, I'm more cautious. Non-random association studies are always susceptible to selection bias. Two clinicians, a nurse who calls the doctor, and the doctor who treats decided to treat some veterans versus not treat others. The author suggests that this is likely random because of the massive heterogeneity in who gets treated. And they bolster any natural variation in the study with their propensity matching. So perhaps this is a stronger than the typical non-random comparison study. But it's still possible that sicker patients received intervention and their inherent sickness is what drove the association. The authors do special sensitivity analysis to argue that this is unlikely to be confounding. Okay, maybe. Dr. Anil Malcolm, a super smart academic internist, pushed back on my caution by saying on Twitter, quote, "There's no clinical equipoise here or expectation that bringing a number down will change any of these outcomes for non-cardiac hospitalizations." He said this is more of a one-sided analysis of the harms of an errant practice. And of course, when I wear my doctor hat, I agree. Proponents of anything aggressive bear the burden of proof. Pathos tells me that this association is likely real. But when I wear my neutral Martian science adjudicator hat, I have trouble knowing if this is one of those trial emulations that would align with a proper trial. The answer, of course, would be to do the trial. An elder with a systolic blood pressure above a certain number could be randomized to receive intensive blood pressure lowering or not. Then you can follow for outcomes. Now, that's not likely to occur. So we're left with our experiences, pathos, and this bit of data. And I conclude by remaining more afraid of aggressive treatment of a number than leaving it alone. But I'm not sure that this data moves that belief much. And that's it for this week in cardiology. As always, I'm grateful that you listened, and I'm especially grateful that people are writing to me and disagreeing and giving me great comments and teaching me. This is wonderful. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even those 1 or 2 sentences review go a long way to helping others find us. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.